Okay, good afternoon, everyone. Welcome to the Palliative Care Benefit Work Group. This is our third meeting, and I'm delighted that you're here. Thanks for your time and your partnership on this work. So I'm Nico Jansen. I'm the Senior Health Policy Analyst, and I'm representing the Office of the Insurance Commissioner, OIC, regarding this work. So before we get started, we're going to do a land acknowledgement, and I should just also state before that we are recording this meeting. This meeting will be posted on the webpage that OIC has set up to host information about this work group. So I'll just state that. Okay, so we'll start with the land acknowledgement. We're meeting virtually from Olympia and Tumwater on the traditional territories of the Coast Salish people, specifically the Nisqually and Squaxin Island peoples. Olympia and the South Puget Sound region are covered by the Treaty of Medicine Creek, signed under duress by the Coast Salish people in 1854. The OIC and Washington state employees respect these lands and tribal sovereignty. We acknowledge the tribal governments and the Coast Salish people living on and taking care of these lands. Okay, so thanks everybody again for joining. Our agenda for today is that first we have two fantastic presenters. They're going to do a joint presentation, and I'm excited about that to help inform the work group. And then next, and I think this will be relevant to the presentation as well, I'm going to provide an update for the OIC on our work to secure the actuarial analysis to support this work group and help with the preparation of the report that will present that actuarial analysis. And then last on our agenda today, I want to begin discussing the parameters or the assumptions that the actuarial analysis will use, including many of the factors that the legislature has set up in the bill for us to consider, such as what services would be covered, who is eligible, how would eligibility be determined, and the payment model, the payment mechanism to be used. So that's our agenda today. And I booked the 90 minutes. I don't know if we'll need the full 90 minutes. It's there in case we do. If not, we can end a little early and refund you some of your time. Okay, so having stated that, I'm going to turn it over to our presenters today. First, we have Dr. Greg Vandekieft, and I've had the privilege of meeting Greg a few years ago. His advocacy before Congress on palliative care issues. I know Greg's background is as a family medicine doc, I'm sorry. And he's representing the Providence system as a palliative care physician and clinical ethicist. Then our second presenter is Tori Fields. I haven't met Tori yet, but I've heard Tori's name come up in multiple conversations with some of you about palliative care. I understand that Tori brings a background as an actuary and a health economist, which is fantastic. And I know Tori has worked with other states on palliative care benefit design, in-state Medicaid programs, and is involved in the Center to Advance Palliative Care. So with that, I'm going to turn it over to Craig and Tori.
Thank you, Nico. And can you hear me okay?
Yes.
Good. Okay, let me get my other screen up here and share properly and go over to a screen sharing mode. Are you seeing, well, one second here. Let me go to slideshow. So are you seeing just the slideshow or do I need to invert it?
Yes, we're seeing
We see just the slideshow.
Oh, cool. Okay. Well, first off, it's a privilege to be able to present with my friend and colleague, Tori Fields. I knew Tori before she was the big name in the field that she is now. And so it's been a real treat to watch her leadership grow as somebody who's really helped a number of states develop palliative care plans and benefits for particularly for the public service plans such as Medicaid. And so she and I have decided to kind of divide this presentation up together. I'll just give a caveat that some of the material I'll be presenting early on is going to be very familiar to some of you, but I didn't know how many of you were at what depths of understanding, so I decided to go a little more potentially basic than that. And I also want to acknowledge the Washington State Hospice and Palliative Care Organization, who I am officially representing in this work group and who nominated to put me forward. So thank you to Barb and Leslie and others from WSHPCO for the opportunity to serve in this capacity. Tori and I are going to try and touch on 4 different aspects of palliative care as it pertains to the work of this particular working group. I'm going to first go over some general clinical domains and clinical services that palliative care covers. Tori will talk a little bit about some of the existing coverages and perhaps more pertinently, deficits in coverage for palliative care within historical payment structures. Then I'm going to talk a little bit about some of the different elements that have been prevalent in successful community-based palliative care models. And then Tori will do a little bit deeper dive into some of the essential elements for comprehensive, cost-effective palliative care insurance benefit. Tori, before I move on, is there anything more you would like to say about your own introduction, or have you been introduced to your satisfaction?
Oh, that's very sweet of you, Greg. Just want to say aloha here from Hawaii, where we are currently implementing the community palliative care benefit. That was the first state plan amendment approved by the federal government for Medicaid beneficiaries. And one thing to just highlight is that my team has had the great opportunity to work in partnership with the National Academy for State Health Policy in developing state Medicaid palliative care benefits, including working with the Medicaid team in Washington on the avenue or the strategy for the public health plan there. When I'm not traveling around in Hawaii, I am a Washington resident, so it's really great to see some familiar faces on this call and to really be able to support this effort in my home state.
Thanks, Tori. All right, so this is a reference to the National Consensus Project's clinical practice guidelines, 8 domains of palliative care. I suspect many of you are familiar with this. It was referenced in the BRIE collaborative report that we've referred to previously, and I won't go into great depth here. There is a hot link at the bottom of the slide, so if you do access the slide deck, you can easily access this. But this is really sort of the Rosetta Stone, if you will, regarding palliative care. If you're really looking at what does palliative care encompass, structures and processes of care would be things like hospice models, home health, community-based palliative care structures. Physical is managing the symptoms, psychological and psychiatric, self-explanatory, as is social, spiritual, religious, and existential. Cultural, there's so many domains of cultural that really cultural humility is a never-ending opportunity to learn. Care of the patients near the end of life. And I like that that's actually the next to the last domain they cover, because so often when people hear palliative care, they jump right to end of life care, but there's so much more before. And then as a clinical ethicist, the ethical and legal aspects of care are something that remain very pertinent to the work I do day in, day out. How is that care delivered? So the patient and family are always at the center, and we talk a lot about goal-aligned care. And as we're looking at quality measures, as we're looking at financial measures, that all needs to build on the solid foundation of, is this the best care for our patients and our families, the people we serve? And I might even say, is it the best care for the people we serve first, because they are people first and patients second. So the core interdisciplinary team involves the provider, physician, PA, nurse practitioner, nurse, social worker, chaplain. In fully functioning programs, pharmacists are a part of the core team. Unfortunately, there are a lot of programs where the pharmacist is not yet fully integrated. And in many programs, chaplains are really brought in sort of extraneously as opposed to being a core member of the team. There are different ways we can work around that, as we'll address today. This model was heavily referenced in the BRIE collaborative report. And what I like about this is, you have the disease management on one side, palliative care on the other. So if you're a newly diagnosed cancer patient, you're going to first want to come in with efforts to try and achieve a cure. And yet palliation is going to be important. So transfusions to boost your energy level, anti-nausea drugs, antibiotics, hormone therapy is both curative and palliative. And so the disease management aspect of this so-called bow tie model is really an important element. But so is the palliative piece. And one of the things I like here compared to the older model that we used to utilize a lot out of the Center to Advance Palliative Care is it only went to end of life care and death. And this bow tie model says, no, there are a number of people we're going to see who are long-term survivors. And so I specifically circled the survivorship aspect. I think about our outpatient palliative care clinic in Olympia. One of our early patients was a gentleman with head and neck cancer who had full resolution of his cancer, as far as we could tell, with years to likely decades of life ahead of him. But he was miserable. He was malnourished. He was depressed. He was isolated. He had severe pain from the cancer, the surgery, and the radiation therapy. He needed palliation, even though he was a long-term survivor. And so I think it's important as we move forward in this world of looking at palliative care benefits that we think about survivorship and long-term management, not just end-of-life care. So what are triggers that might lead to goals of care discussion with patients and families? And this is as relevant to a primary care provider as it is to a palliative care specialist. Would I be surprised if my patient might die in the next year? If they're older than 80 and are hospitalized, it's worth taking a moment to say, what are our goals of care here? I'll just share a quick story. When I was a brand new, wet behind the ear family doctor, I was admitting a 93-year-old guy with brisk rectal bleeding. And I said to his son, well, let's get him set up for a colonoscopy. And his son says, whoa, 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 doctor. Before we get into all these procedures, let's talk about what our goals are. And it was like, whoa, this was a patient's son who taught me a very valuable lesson that to this day really has a strong resonance for how I look at patient care. Specific diagnoses that might raise the question of goals of care. People with multiple advanced comorbid conditions. Our Washington Rural Palliative Care Initiative, the majority of the patients we see are not eminently end of life. They're dealing with chronic, complex, multiple comorbidities. Progressive functional decline. At what point in that process are the therapies taking more out of the patient than they're giving to the patient? And we ought to reconsider the treatment goals. And then what about the absence of disease-specific treatment options? You think about a lot of our neurodegenerative disorders where the treatment options are from the get-go more palliative than curative or disease modifying. Now, one of the things I think Tori will probably talk a little bit more about, but she and I have talked about a lot in our interactions, is the distinction between primary and specialty palliative care. As a family doctor, I sometimes bristle a little bit because when I manage asthma, early emphysema, when I manage a lot of medical conditions, I don't think I'm doing primary pulmonary or primary cardiology. I'm practicing family medicine. That's what I do as a primary care provider. But for the sake of clarity of terminology, we do tease apart primary palliative care, which is what any primary care clinician or relevant subspecialist. If you're an oncologist, a cardiologist, a nephrologist, a pulmonologist, you're going to do a lot of palliative care in your practices. But there comes a time, just like as a family doctor, I need to refer to cardiology, I need to refer to nephrology, where it's appropriate to refer to specialized palliative care. And so one of the things we need to figure out as we're working on our benefit is where do we try and augment primary palliative care versus where are we really designing a system that's going to support referral and coverage for the full interdisciplinary palliative care team. What is involved in primary palliative care? Assessment and control of pain and symptoms, providing psychosocial, social, or family support, discerning treatment goals and aligning with available treatment options. And that includes the assessment. And there are times where an added layer of complexity in the primary care setting is doing an in-depth assessment. This is a complex patient. At what point do I need to think about managing them within the palliative or the primary care team, especially if I have a patient-centered medical home practice, which tends to be more robust and interdisciplinary, versus when do I actually need to refer out to, co-manage with, or collaborate with my palliative care specialty colleagues. Specialty palliative care, that's where we tend to get more into complex symptom management, complex goals of care, discerning, as one of my hospitalist colleagues like to say when he refers to palliative care, these are the people who are going to help you navigate your way through the very complicated and potentially turbulent decisions you have to make in the face of the serious illness you and your family are dealing with right now. And he uses language I really like. He doesn't say, I'm referring you to palliative care, which sounds like a handoff. He says, I'm going to invite palliative care in to be a part of our team. And that way we're all in alignment as a team together, as opposed to the patient and family feeling like they're being shunted off to a different service. I'm also going to call out here interdisciplinary versus multidisciplinary. When I round in the hospital, if I read a social worker's notes, if I read a nurse's notes, if I read a chaplain's notes, I'm deriving important information, but it's multidisciplinary. We're sort of doing parallel play. Interdisciplinary is where we actually sit down and have an intentional team meeting to talk together as different disciplines and shape the care plan with all the voices heard together into a common and agreed upon plan. And that's the distinction between interdisciplinary and multidisciplinary, I would call out. And so palliative care is no longer simply upstream hospice. Back in the late 1990s, when I was first doing this work, we actually billed ourselves basically as a bridge to hospice. And then things evolved. The first study started coming out showing early involvement in palliative care during cancer treatments, improved patient quality of life outcomes, improved financial outcomes, improved length of life of all things. And so palliative care, the Temmel study that came out in around 2012, the running joke was, if palliative care was a drug, we would have a huge market share. They would invest all this, but it's a multidisciplinary psychosocial intervention, so you don't get the same juice behind it that you would if we were a drug that a pharmaceutical company could make huge profits off of. And so we've moved from the either or curative care versus comfort care model into the so-called concurrent care model, where many of our patients in our palliative care clinic are still undergoing chemotherapy, are still looking into undergoing procedures like a TAVR, a transcatheter aortic valve replacement. We're not doing it after the curative or the disease-modifying treatments. We're doing it concurrently with the curative or disease-modifying treatments. And finally, the team-based approach. I talked a little bit about that. I really like the idea of the shell here, because if you've got a physician who's rowing balls out, pardon the expression, while everybody else on the team is rowing in a different rhythm, things are unstable. It's topsy-turvy. And so getting every different discipline, the physician, the nurse, the social worker, the pharmacist, in sync and rowing together is really crucial for the smooth delivery of efficiently and effectively provided care. And then lastly, part of why I'm a big fan of primary care, aside from coming from a family medicine background, I love this quote here: all people with advanced serious illness should have access to skilled palliative care, or when appropriate, hospice care in all settings where they receive care. And so building up primary palliative care skills, looking in our hospice deserts in the most remote parts of our state, figuring out ways to get those services to everyone in the state is really an equity issue. You shouldn't have to be deprived of access to high quality care just because you live in the Okanagan Valley and have to drive 4 hours to get that care. There are ways that we can get that care to you. And with that, I'm going to pass the baton to Tori. Tori?
Awesome. Thanks, Greg. So at some point during this presentation, I will go off video just to sort of save bandwidth over here where I am. But one of the things that as an actuary or as a service designer, you do or you learn is that the information that is provided to you about the clinical model is really what drives the reimbursement, drives the policy, drives the procedures, and ultimately drives the contracting. And so it's really important. I'm excited to be able to partner with Greg on this so that he can really lay out what is the best model for community palliative care. It's interdisciplinary. It has billable and non-billable providers. It's longitudinal in nature. It allows people to have their needs and their goals really drive the care plan. And so one of the things when you look at benefits overall is that fee for service largely doesn't work when you're thinking about an interdisciplinary care team that is going to have a care plan driving the services that someone receives. And so in looking at Medicaid benefits across the country and, in addition, commercial health plan benefits across the country, what we found nationally is that there's no palliative care benefit available in any setting. palliative care is being paid for currently under fee for service. And that is something that creates this a la carte type experience for a patient, where a lot of the palliative care delivered in the community today is delivered by billing clinicians, namely NPs, MDs, and social workers. And if you think about the move from multidisciplinary to interdisciplinary, what you need to do is really figure out a way to pay for some of those additional services that make up high quality palliative care. In the hospital, they have figured this out in some ways because palliative care is included as part of the DRG payment. And so what you've seen is an increase in access and availability of inpatient palliative care teams, not just inpatient palliative care providers. You see on the federal side that some specialties have requirements around palliative care consultations, including things like LVAD procedures, where an LVAD must have a palliative care consult prior to LVAD placement. So we know that there is some inroad in terms of expanding or delivering palliative care, but the majority of that has been on the hospital inpatient side. And palliative care is something that is concurrent and upstream from hospice and outside of the hospital. And that's where we see the main gap in care. A really critically important piece of palliative care that not only makes it work, makes it actually get the outcomes that it's supposed to get, and makes it different from hospice care, is this notion about care coordination and being able to have tightly coordinated care, not only across the interdisciplinary team, but also across multiple specialists, supplies, durable medical equipment, prescriptions, et cetera, and the other programs and benefits that a health plan offers. And so that's really, if you think about the premise of why a payment model needs to be developed, or a benefit for palliative care on the community side needs to be developed, it's really working to close that gap and improve coordination of care and the delivery of care through a team. Go to the next slide. In developing a benefit or a care model, there are a number of questions or steps that need to be taken. And so this is something that, if you're working with an actuarial firm or you're working with an organization that is supporting benefit design, the first thing to do is to agree on that standard definition of palliative care that you're looking to deliver. And actually define the services that are part of palliative care. So the team, the services delivered, the minimum service requirements, et cetera. And then as part of your benefit design structure, looking at the benefits that are already available to seriously ill patients and those things that need to be covered in a new and different way. The next piece in terms of thinking about policy route is to think about whether this is something that's going to be on the community side or on the inpatient side, and how far upstream you want to go when you're thinking about the seriously ill population. As an actuary, this 7 through 11 are those places that actually help you determine not only the rates, but the impact on the premium to insurance companies. So if we start to look at how many people might need access to services for palliative care, what the cost of those services actually are, and then if the costs of services can be delivered under the same premium or under you'd have to impact or increase the premium. Those are things to sort of think about. One of the things that we know about palliative care services is that it helps to prevent suffering. And so you largely get cost savings from ER reductions, inpatient admission, reductions in inpatient admissions, and reductions in skilled nursing facility costs, which actually can be significant enough to cover the cost of doing business or cost of the additional services. And that's something that we have found not only on the Medicaid side, but also on the commercial insurance side, that you can actually achieve budget neutrality or keep the premium the same, or can achieve cost savings with implementing palliative care services as part of a health plan's benefits. Next slide. One of the things that needs to be determined by any sort of advisory council developing a benefit is really what are the parameters around the services, around the population, the competencies of the palliative care team, and the care model that you want to select in order to deliver it. What we need to consider too is that because palliative care has largely been delivered fee for service, palliative care means different things to different people, especially to palliative care providers. And so there's an old adage in the palliative care community that if you've seen one palliative care provider, you've seen one palliative care provider. And so the biggest hurdle to get over as you're developing a palliative care benefit is to set a standard for what palliative care services are and who are the required versus optional providers on the care team. In addition to that, because palliative care has largely been the Wild West, we see that there's a lot of need or requirements in being able to have standardized reporting or standardized assessment tools, things that allow for health equity and access, but also help to help the providers actually deliver a standard model of care across different agencies. So those are things to consider as you're moving on this path of developing a reimbursement model and a benefit for palliative care services. A lot of that needs to be standardized upfront because there aren't a lot of expectations right now. Next slide.
I'm going to talk a little bit about when, as Tori talks about the benefit and how it's going to design coverage. Well, who's going to deliver that coverage and in what model? And so types of community-based palliative care, you can have clinics and those can be freestanding. For instance, in Olympia, ours is totally freestanding. They take all comers. Many palliative care clinics are embedded in specialty clinics, and sometimes that means they only see patients with that specialty. But for instance, at Swedish First Hill, they have their palliative care clinic embedded in the cancer center, but they see all diagnoses that are relevant. Home health services can provide palliative care, but that's limited because you have to meet home health criteria. Hospice is probably the most robust palliative care benefit that's out there, but that's limited to people who, by definition, are anticipated to be in their final 6 months of life. Skilled nursing facilities, long-term care, adult assisted living facilities, adult family homes are all sites where palliative care can be provided. And telehealth is a growing area of palliative care. Those are all different models. Who sponsors the programs? Hospitals, home health programs, hospices, medical groups, independent programs, volunteer coalitions. I'm thinking here of the Lookout Coalition in the Okanagan Valley, which is a fairly sophisticated group of volunteers who provide palliative care to a wide geographical distribution. And if you're not familiar with the Okanagan, it's last I knew it was still listed not simply as rural, but frontier. It's so sparsely populated. The PACE program for all-encompassing care for the elderly, that tends to be a very internalized model rather than referring out to different agencies. And finally, integrated payer provider systems. I spent some time on the phone with a doc from Kaiser who did palliative care with their program, and their home-based programs were somewhat still limited to people who would qualify for a home health model, but they also had a clinic that provided very robust interdisciplinary services. And so with Kaiser, it's both the clinical service team and the insurer bundled into one, and they have found that providing palliative care really benefits their population. What are some of the traits of a successful community-based palliative care program? Well, as Tori mentioned earlier, value-based contracting, fee-for-service alone is rarely going to be a sustainable model for palliative care. Strong provider presence. So you need to be able to manage symptoms. You need somebody who can coordinate the interdisciplinary team. And as a provider, I can say that often my strong provider presence is leaning heavily on the social workers and nurses to tell me what to do. And then I get to look like I'm in charge, even though they're really the ones who are telling me what to do. We need to be able to assign patients a level of acuity so you know how much intensity of service you're going to need. It's one thing to have a person with multiple sclerosis who's in their long plateau phase. It's another if you have somebody with multiple sclerosis who's declining rapidly and having recurrent infections and pressure ulcers and really needs intensive care. Defining the scope of services. You need to be very clear what's in service, what's out of service. Otherwise, you're going to wear your team out, have burnout, and lose clinicians. Strong relationship with primary care and relevant subspecialties. I spend a lot of time on the phone as a palliative care clinician, talking with primary care providers, talking with hospitalists, talking with relevant subspecialists to make sure we're all on the same page and the patients are hearing consistent messages rather than getting mixed messages. It takes a lot of effort to do that. We're not always successful, but it's still important. And then lastly, a 24-hour call center. This Kaiser doc I was talking with, their home-based palliative care patients, their clinic patients could call in 24 hours a day and would get a palliative care specialized clinician. Often it was through their hospice program. They innovatively were able to share a call between hospice, which always has 24-hour coverage, and their community-based palliative care programs, which often don't. But this way, all of the people being seen by their palliative care teams had access 24 hours a day. Providence has had a successful program in the San Fernando Valley in Southern California. And so I reached out to their director to say, tell me what's important to make it succeed. And these are the things he shared. Define success measures from the outset. So before your program goes live, already have an idea of how are we going to define success. Know your costs up front. But then the third bullet point was important. Be prepared for unanticipated costs here and now, but in the long run, you can anticipate costs for expansion, growth, education, training. Be prepared to deal with those costs because that's an inevitable part of a successful program. Leverage support and look at pre-existing infrastructure. I talked about Kaiser. Their programs are building on their hospice models so that they have a richer, more robust infrastructure that's already in existence. They didn't have to create it from scratch. And then finally, be ready to course correct based on feedback and data. You're going to find things that you didn't expect and be prepared. The Plan, Do, Study, Act, a small test of change model is going to be important. And so sample care model that's highly successful, you have a palliative care nurse who does the initial assessment. They review eligibility, determine is the palliative care program the way to go? Should we consider referring them to home health or hospice instead? Then bring in the provider who does symptom assessment, general management plan. You use your acuity to determine how many visits are they going to need? Do I need to see them weekly, once a month? How often should I see this person? Based on acuity, determine that frequency of visits, and then have after hours available with a skilled triage nurse who knows I need to call a provider at 10 p.m. or 2 a.m. versus I can batch this and call the provider at 7 or 8 in the morning and talk about it then. Social workers are involved in the care planning and then as needed by referral, and at least a lot of models of spiritual care is by referral. Some do have their own chaplains, especially if they're involved with hospice. Sometimes it's community volunteer clergy, so each program sort of discerns what their needs are. And Tori, back to you.
Great. Thank you so much, Greg. One thing to note in terms of the typical care plan and the care team, that all really, if well defined, as he laid out there, can really be rolled up into a cost model, something that actually can calculate a per member per month or another type of value-based payment, a bundled payment approach to services. In order to really develop a health plan benefit that includes or covers everybody, something that we're talking about here, the first thing is to really look at the overall population, broken out by line of business and your coverage types, what your plan types look like. Identify the population of people with the diagnosis of a serious illness, and then actually start to model out the population of people who have needs. So as Greg was saying earlier, there's a difference between primary palliative care and specialty palliative care. And we expect or anticipate primary care providers or specialists to be able to do some of that primary palliative care type service, and then to refer to subspecialists or specialists when needed. And so one of the things to look at is really what's the volume or the view of the population of people with serious illnesses, and then what's the population of people who have serious illness plus need. You can start to use utilization or other risk scoring type of things to really look at what those numbers might look like. In order to develop eligibility criteria, it's important to actually look at the population and the prevalence of a serious illness by age category and by condition, so that you can really get the eligibility criteria right. Once you have a view of the population, that's when you can start to model out costs. So as I shared earlier, the real driver or impact of palliative care services longitudinally is reducing unnecessary inpatient admissions, ER visits, and skilled nursing facility stays. So it's important to really start to look at what the baseline costs and baseline utilization is for people with serious illness in those benefit categories, so that you can model out what the cost reductions might be when implementing palliative care earlier. In addition to that, what we have found across the country is that early palliative care intervention actually helps people have a longer length of stay on hospice and get them to hospice earlier. And so one of the other impacts to cost is actually an increase in hospice utilization or hospice length of stay. So that's one thing to sort of think about as you're building out this benefit. On the Medicaid side, we have found across the country that whole state Medicaid plans are able to either break even or save money when implementing palliative care as part of their essential health benefits. And so, that's something to really model out, is what is the break even rate, and what can health plans afford to pay from a PMPM standpoint, in order to make sure that you're covering the cost of the full interdisciplinary team across settings. Some of the questions that I would encourage you, work with your actuarial team on as you're developing out this sort of benefit plan are looking at the payment methodology, whether you want a bundled payment, whether you want tiers to that bundled payment based on setting or acuity. And then estimating the rates for services that will help to achieve, cost savings or budget neutrality, so that it doesn't necessarily drive up the premium costs for the benefit plan that someone has. What we would hate is to reduce access to overall healthcare coverage by implementing palliative care, but that is something that we have ultimately not seen to date over the last 15 years that I've been working on this. Next slide. So in terms of thinking about the drivers that go into a cost model, there are four main drivers in developing a PMPM amount for palliative care services. One is the eligible population. So how far upstream do you want to go in terms of who would you cover for palliative care? The second is really what are the outcomes, as Russell Kiefer on that slide stated. Make sure that you're starting with an outcomes plan in mind. And so define the outcomes that you're looking to see, largely reductions in hospitalizations or ER visits. And then defining the care team and the services. So really taking what Greg has been presenting and quantifying the care team, the staffing, their wages, the administrative and overhead costs that would be anticipated for that palliative care team, especially if they're delivering it in the home setting or in rural settings. And then protocol for services that would be delivered by that care team. Next slide. Just a note about identifying the target population. The National Quality Forum in 2019 developed a work group of national leaders and researchers and experts in developing a standard definition of serious illness. And so this gets into a little bit more granularity of how do you separate out the population who actually needs interdisciplinary specialty palliative care services. So if you look at your overall planned population, we know that there is a considerable part of the population that is not seriously ill at all. So of course, those would be people who don't need specialty palliative care. There's a second group of people that has the diagnosis of a serious illness, but are able to really be managed by their primary care provider or their specialist. And so those are individuals who are really great candidates for primary palliative care, where you have increased care coordination, you have advanced care planning, goals of care discussions as part of standard care for that diagnosis. Now, what's really important to define is this this divider line between this A and B, where somebody has a serious illness and has additional needs. So either they have a decline in function, or they're starting to utilize the hospital to manage their pain and symptoms, or they're having significant caregiver burden. Those types of things are areas where the individual becomes much more complex, needs an interdisciplinary team to really be able to manage that plan of care and to help them along their way longitudinally. And that's really the sweet spot where we see specialty team-based palliative care benefits being really, really important for the patient and family. If you look at C, that is when a person has a serious illness, they have functional decline, and they're not able to manage on their own. And that's where you start to consider things like hospice care, where they are, they're continuing on that trajectory, need a lot more services, a lot more intensive coordination, and would be a better candidate for hospice rather than specialty palliative care. So I like to help folks understand that, hospice is a setting for palliative care services, but it doesn't go far enough in terms of meeting people where they are when they have a serious illness and are starting to need more help and support. So we're really trying to look at, what's the eligible population in that B category. Next slide. The best approaches to palliative care services, the payment model, and what we've rolled out for Medicaid plans across the country, as well as some commercial insurers across the country, is really a bundled payment model that covers all of the services that an interdisciplinary palliative care team would be delivering longitudinally. This is not an episodic model, so it is a longitudinal model, but it does take all of the best features or elements of, an episode. So think about a mix between home health and hospice, and you get some of that bundled payment approach to care. We've also found that it's important to make sure that you're incentivizing primary care providers and specialists in assessing people for their needs, knowing that palliative care assessments can take a long time. There are a number of assessments in order to meet those 8 domains of care that Greg outlined in the National Consensus Project guidelines, and that it can take some time for providers to determine whether somebody needs primary palliative care or specialty level palliative care. So that's really the payment model. It's the best approach to care and services. Next slide.
Hey, Tori,
Yeah,
this
sure.
is Jane Meyer. Can I ask you a question? Can we go back a slide?
Absolutely.
And I hope you don't mind that I'm jumping in the middle.
Oh, I do not mind at all. And
Okay,
I
great.
apologize for the background noise. I'm in transit.
Don't worry, don't worry. So, and this might be for both you and Greg. I'm just trying to figure this out because I think I heard you say, or Greg, that somebody's primary care doc, or if they have cancer, for example, their oncologist might be providing sort of components of palliative care as part of the team. When you're looking at a bundled payment model, would the bundle payment model also include like the services that are provided by a PCP or a specialist physician, even though they're probably
Oh,
billing an E&M code for the visit?
that's such a great question. So it actually wouldn't. So
Okay.
instead of it being so if you think about hospice care, hospice is like a global bundle where everything is included as part of hospice care, right? And largely that can work out because as part of hospice, you are agreeing to forego curative treatment, right? But with palliative care, as Greg was saying, it's concurrent with other services. So you would highly anticipate that somebody is still going for oncology treatment, that they're seeing their cardiologist, that they're seeing their primary care provider. And the bundled payment is actually for the services delivered by the palliative care team.
And Tori, I actually went back further to your funnel slide, where the top layer, the green, not seriously ill, they're not really thinking about palliative care at all. But that first category A would be where you would expect primary palliative care to be delivered. One of the things Tori and I have talked about is should there be an augmented payment for somebody who requires a higher level of assessment for potential specialty palliative care needs, even if they haven't been referred out. And I have seen some places such as Portland where some of that model has been worked on. I don't know that it's reached full maturity, but then a category B would be when, okay, we're bringing the full specialized interdisciplinary team into play. And so, Jane, I think your question is spot on that how much do we look to juice the primary palliative care versus how much are we looking explicitly to create a benefit for specialty palliative care? And I don't know that we have the answer to that yet.
Okay.
What we are doing though, Jane, in and what we got approved by CMS for our state plan amendments is this, Greg, if you go back to that bundled payment slide. So if you think about the assessment being going through having a primary care provider or a specialist go through the initial assessment of a person to say, what are your needs? And how can I assess for somebody's goals for care, go through social determinants of health or social risk screening, go through a functional assessment and their cognitive assessment, et cetera. That alone can be an intervention in and of itself. So if you think about being able to add the assessment component to it, at the end, there's a care plan that is developed. And that care plan can be performed if you're thinking about like oncology care model or the oncology medical home, that assessment can be performed on its own. At some point, there's going to be a person who actually needs more intensive services. And that's when a referral, out of that assessment comes a referral to team-based community palliative care. And so the way that we have really built this into the models is to enhance fee for service. So enhance the payment for primary care providers and specialists to actually perform these assessments ongoing, and then also cover the costs of the specialty palliative care team when somebody really needs those services in place.
Okay, I'm just trying to figure out, and we're going to talk more after your presentation about what we're asking Milliman to run. And so these are the kinds of questions that come up in my head so that they know what they're running, right? They know what model they're running to try to figure out who's providing what service.
Right. And we have, like, as part of, Yeah, and as part of the assessors, that's going to be a larger pool of providers than providers who are, specialty level palliative care teams that are being paid for the bundle.
So Greg, in the people who are in group A in the funnel, when you said really the services can be provided by the person's primary care doc, right? It sounds like. Would those people be paid through the bundled payment methodology, or would we be making an additional payment to the primary care doc that's doing primary palliative care? How would that happen?
Yeah, so I don't see that payment coming out of the bundled payment since that tends to be more specific to the team. If I had a magic wand, what I would do is create an enhanced primary care benefit akin to the advanced care planning code that Medicare created. And so it's not a large amount of money, but if I am a family
Okay,
doctor and I'm
okay,
seeing a patient and I'm talking to them and doing advanced care planning, I can actually submit a separate code for some augmented payments for the added work, intellectual capital it took me to do that. And Nico, I'm just going to acknowledge that we have hit our time limit, so let you tell us when to give us the hook. But I could talk all day, so but I think, Jane, that's a really important question because I don't think that the Medicare or CMS models do a good job of actually creating that distinctive payment for the assessment part that Tori was just talking about. That would be something that we could look at, but it would be different than what they're doing at the federal level. Tori,
Yeah.
you know way more
The
about this than me, so
the
let me turn it back to you.
I would agree that they're not doing that in a good job at the federal level. I would say, Jane, the assessment code is payable separately, right? And so
uh-huh,
that is the magic wand payment that Greg is asking for,
okay,
which is it's higher than the advanced care planning rate. It's
uh-huh,
more equivalent to a like a 99215 or an enhanced 99215.
uh-huh,
So in states, it ranges from $150 to $200 for that assessment. And that is then enhancing the fee schedule to allow for, as Greg was saying, the time it takes to do the assessments, the intellectual capital that it takes, et cetera. And that can then yield, if somebody actually is in that B category, somebody starting to receive the bundled payment for services, but they actually are to be leveraged separately.
okay, thanks. That's super helpful.
Yeah. Um, the and Nico, really let us know when we have the hook. But I think this is my last slide. The things that we have found are that the savings and the payment have largely differed across states because there have been differences in baseline costs and baseline populations. So I've actually run this model for 22 states now, and we've been able to really see that there's a cost savings across the board if you implement palliative care services. The amount of savings that people get has to do with the baseline costs. So how often are people admitting to the hospital today with a serious illness? So this is something that is layered into somebody's other benefits and into the healthcare system. Some of the things to just sort of help the actuaries or the folks who are looking at data sort of navigate is that some costs are underreported. They're not all being billed for, and you're only as accurate as coding accuracy. So what we know about dementia is that dementia has not always been, accurately coded. And so you're going to likely have the eligible population be an estimate. You can't be exact all the time. From a utilization standpoint, we do find that palliative care can drive cost savings and that it can drive enough cost savings to reallocate those savings to a pretty substantial per member per month that covers the cost of the care team that delivers services. And the Providence in Southern California was one of my best teams that I worked with at Blue Shield of California, running the managed care plan in the state. And I think what we were able to really prove together was that you can pay providers a meaningful, sustainable rate while also making it financially, feasible for the health plan. So that's something that we have identified pretty easily. Those savings are largely from inpatient, emergency department, and facility stays. And there are some additional costs that are incurred with, a longer length of stay on hospice. But it's very rare to be able to find a program or a model that both saves money and is the right thing to do. I think that's my last slide, Greg.
It is, and I'll just kind of put a bow on it by commenting that at the end of the day, the first priority is goal-aligned care. We're not trying to withhold care that people want or would be of value, but the truth is we tend to overtreat in American medicine. And doing this work for quite a few years, there are many times that when we parse out what do the patient and their family really want, it's often focused in a way that leads to less care. And that's where the cost savings is a bonus. It's not the driver. And so we have a slide with some resources. California Healthcare Foundation did some really good work on outpatient palliative care. Center to Advance Palliative Care has a few things. Tori referenced the National Quality Forum work, and then a couple of articles here on generalist versus specialty palliative care and that sort of thing. So with that, Nico, I will return the screen to you, and I apologize for running a bit over. Like I said, we get excited about this and we could just go on and on. So thank you for your patience.
Yeah, absolutely. No worries at all. And thank you, Greg and Tori. And it's 4:29. I do think we have a few minutes. If those on the call want to add anything, comments or questions based on the presentation, it was really informative for me, and I agree with Jane. What we want to work towards is determining what assumptions the actuary, in this case, Milliman, will be modeling. And I think what you covered are a lot of those questions. Tori, I think, had a slide of those 10 questions. So this is very relevant. So I'll open it up. Feel free to raise your hand on Zoom. If you can't find that, then you can go ahead and just unmute. I see Barb's hand just raised. Go ahead, Barb.
You're muted, Barb.
I'm not hearing you right now, Barb. Still not getting any audio from you, Barb. I'll let Barb work on the audio. I know it can be really tricky and always simple. Think it's simple, but it's not simple. Anybody else of our work group members have any questions for Greg or Tori or comments? So I had a question, Tori. You were talking about the cost savings that you've seen in states you've worked with. Does that apply for state Medicaid programs who are doing the state plan amendments and the commercial markets in those states? Are those types of cost
Yes.
savings you are presenting representative of both markets?
Yeah. And one thing, Nico, to share is so I worked at Regents running palliative care, and worked at Blue Shield of California running palliative care across all lines of business. And we saw the same results across all lines of business. The Blue Shield of California published our results of the palliative care payment model. And we saw cost savings across the board across commercial, Medicare Advantage, and Medicaid, using the same model and the same reimbursement structure. And what you're seeing is commercial health plans have actually been in the game a bit longer than Medicaid has, where if you look at some organizations like Aspire or Landmark, these home-based palliative care or home-based primary care organizations, they have generally saved, the same savings that we're talking about here. And Kaiser has a long history of publishing their savings as well. So in the PPO population, especially, and the exchange population, you see even larger savings because care is a lot less coordinated. And I was quite surprised being on the commercial side when our exchange population and PPO population actually had more savings than our Medicare Advantage.
I had a question about the payments. I can't figure out how to raise my hand, so.
No worries, Marcia. Go ahead.
Sorry, is the proposal that a specialty palliative care team would only receive the bundled payment and no longer do a fee for service payment, or is it a combination?
It's a combination depending on patient eligibility and their need for an interdisciplinary palliative care team. So you would imagine that palliative care providers could provide palliative care consultations for a person who perhaps is in that A category, right? But the proposal and what we've done in other states is actually have a bundled payment where basically as a palliative care team, for those where you're getting reimbursed through the bundled payment, you're sort of giving up your right to bill cobbled together your fee for service codes, right? So it's specific to the sort of patient provider combination.
Okay, so the payment would then need to be robust enough to reimburse for those provider visits that are doing complex symptom management and goals of care conversation.
Yeah, that's right. And some of the things that still get billed outside of the bundle are things like LCSW visits that are related to behavioral health, things like that just are not sort of palliative care services.
Thank you.
Nico, I'm going to kind of jump the queue here and I'll say, Tori, I think Barb's question that she put in the chat box really correlates to what you were just sharing with Marcia, which is my question is about the difference between quote unquote covered services and quote unquote required services. Is it important to have a statute or rule that requires services to avoid certain providers from offering only a la carte services because they're covered?
Yeah, Barb, it's a really great thing that you've brought up. I think one of the things that has been really difficult for specialty palliative care is that there are lots of different definitions of what is palliative care out there. And so it actually makes it very confusing to the general consumer to find the services that they need if it's not standardized. And so as part of the sort of regulation or the state plan amendment, we put in place, what is the definition of palliative care services? So you can't own or own the definition of palliative care, but you can define the services related to palliative care. And that's a really, really critical piece to do upfront that says this, when we talk about this interdisciplinary palliative care services, we're meaning one thing. We're not letting people choose their own adventure. That even if somebody has an individualized care plan where somebody may have different members of the team that they access all the time, the availability of all of those services, it's what makes you a specialty palliative care provider that's able to be reimbursed by that bundled payment and create sort of a standard across the board that's necessary. And one thing to just call out for the group, as a health plan, what we did at Blue Shield of California was we put into our specialty palliative care contracts that providers could achieve they could achieve these requirements by going after Joint Commission, ACHC, or CHAP certification for community-based palliative care. So there are already certifications out there that providers can move forward with and work toward, that can be really helpful in these situations where you really want to pay differently and you want to make sure that it's a standard model, and that there is there are certification standards that health plans can help to leverage.
Looks like we have a question from Leslie Emmerich. Leslie, if your audio is working, you want to just jump on and.
Sure. Tori, when you've been doing the actual actuarial analysis all these years, probably much like Washington State, they don't want to book the savings. And my concern is when we do an actuarial analysis that's going to show the costs, for each of the populations, how are you able to show legislators that it's a budget neutral or even a cost savings if they're looking to mandate the program?
Leslie, there is an exorbitant amount of evidence, not only in published literature, but in repeat, routine health plan evaluations. And there has been enough, there's been enough published across states to actually book savings. What we did in Hawaii, though, was we didn't book savings, we booked budget neutrality. And so I think that's really important. In California, under SB 1004, with the Medicaid benefit that we developed there, we made that a managed care mandate without any additional dollars from the state. And that actually is achieving a similar goal, right? It's where you're saying this is a required benefit that health plans cover, and we're not going to give you more money for that. And you can't increase the premium. And so this allowed the managed care plans to achieve the savings. And HealthNet, Partnership Health Plan, and Blue Shield of California, 3 out of the 7 California managed care plans all have published their results. All of them have savings. And in the California Advanced Illness Collaborative, which is part of that California Healthcare Foundation work, 100% of the managed care plans booked savings. So, I think that if you're looking for a precedent that was set, California has already sort of achieved that. And we've started really encouraging health plans to publish their results so that we can get over that hump that you're talking about.
Yes, I'd love to think that once we get this actuarial analysis done, that insurance companies and the Medicaid program will do the right thing and implement it. But it's a good chance that we're going to have to go back to the legislature, and the legislature is going to ask for a fiscal note on it. And I just want to make sure that we've done the best job we can to show budget neutrality, however that works. And maybe that's the California bill language. I don't know yet, but
yeah. And under the state plan amendment for Hawaii, budget neutrality was approved. So the Office of the Actuary had to sign off on our numbers. And that was Milliman in Hawaii plus my team who did that work. So, something to sort of, we can talk about that at a later date after you've sort of engaged or started talking to Milliman, how we can help to, cross the Pacific Ocean divide between the two.
Great. Thank you, Tori.
And Leslie and Tori, I think to your point about how the potential cost savings and avoiding, avoiding utilization as a result of palliative care that would reduce savings. To your point there, I think we can certainly discuss that with Milliman, make sure that they have all of the data that's out there. And so I'll get to this in a minute in the next portion that I want to cover in terms of where we are with that contract, but we can certainly have Milliman consider that and any data as part of their analysis.
Barb, you asked a question about the eligibility criteria, and in I definitely have my own thoughts about this, but in California, we used a retrospective look back on the vital statistic records. And that was a really interesting experience because we were really looking at people who were 1 year out from death and made the eligibility criteria generally narrow. And that was a decision that was made. It was a design choice. In Hawaii, we used a population-based approach to palliative care eligibility that was not prognostic in nature. And we're seeing that happen in New York and in New Jersey and in other states where we're taking the approach of really leveraging Amy Kelly's definition of serious illness to look at a population health approach to services. And there's a code set that we have provided to HCA on the Medicaid side to identify the population of people with serious illness. That can really help to do that more, prospective view of eligibility rather than an eligibility that is prognostic based. Greg, you're on.
We see your screen though.
Yeah, I just shared, this is the PAXI tiering, and PAXI, the patient and caregiver support for serious illness model, was really designed very specifically as a CMS model, so may not be directly relevant to us. But we had talked about this at a previous meeting when I know Jim Fausto had raised the question of how do you identify the population. So this is just one exemplar model of how to go about doing that using both tiering, and you can use the diagnosis of serious illness, functional impairment, or healthcare utilization. So there are a variety of different tools that can be developed that will enable us to identify the patient population.
So my recollection, Greg, and I'm glad that you shared that. My recollection is when we had the presentation on the BRE collaborative report from 2019, and I think there are a number of you who are involved with that or were on that work group. I think that they covered excuse me, the PAXI eligibility criteria as within their recommendations, or at least part of the recommendations. And so I was actually going to ask you about that, but I think that my question is answered because you kind of just covered that. There was also a PAXI recommendation related to the payment model that the BRE collaborative report, and I think that the OHSU and HCA report also discussed. And I was curious as to, for you and Tori, how you feel that the BRE collaborative ideas about that bundled payment approach align with your presentation and what you feel is the best way to have the reimbursement.
Well, I will acknowledge that 2019 for my aged brain has been a while, so I don't remember all the fine details, but to the best of my recollection, I felt like the BRE collaborative really was well aligned with what we're talking about. Both Phil Rogers, who was one of the lead architects of the PAXI model, and Tori have kind of shared with me that because this was really intended to be an alternative payment model through CMS, it had certain elements that may not carry over to the work we're doing. And so we do want to be mindful to not try to pound a oblong peg into a round hole, but I think there's a lot about Paxi to like. Tori, I'd be interested to hear how you would answer Nico.
I think that I think that they are similar in terms of the collaborative recommendations. One of the things that, from my recollection, I think there were some pieces related to how many of the services are you able to bill outside of the bundle, and what is actually the, like what's actually included in the bundle that may be a little bit different between sort of what I presented and what was in the recommendations. But from a reimbursement structure perspective, I think it's relatively similar, except for the payment for the assessment outside of the monthly bundled payment rate. So from a reimbursement structure perspective, I think there's aligned in some ways. One thing to just note is that CMS does have codes for these services that I presented on today. So, the assessment code, the actually monthly bundled payment code, there are actually codes associated. So these are claims that could be reimbursed through claims. It could be adjudicated through claims, which is something that's really necessary if you're talking about a commercial benefit. And so from a Paxi perspective, I think that's a little different. I'll be honest and say, like, I'm a commercial health plan person. So if something doesn't adjudicate through claims, it doesn't matter.
Right.
So this structure actually is something that does work. There are codes, there are revenue codes for palliative care. There are those things that probably were not in the BRE Collaborative or the OHSU report.
Right.
That should, me being biased here, should be leveraged if you're going to work with commercial payers.
Okay. Well, thank you so much, Tori and Greg. I know this went a little bit over, but I think it's really relevant to the last portion for what we want to present to the group today. So thank you so much for your time. I know how busy you both are. I would love to share the slides, and I can add those links also that you have on that last slide, because I think those are some good additional resources that I'm not sure, I haven't seen all of those, certainly for me. So I'd love to also share those with the group. We have a resource library that we can on the webpage for this work group, and I can put it there.
And I'll get those
Okay.
slides to you later today, Nico. So thank you. Thanks everybody for indulging us for running long. Like I said, we get passionate about this topic, but I really appreciate everybody's attention and all the great questions.
Yes, thank you for having us. Have a wonderful rest of your day.
Great, thank you. Okay, so the last items I wanted to cover for everyone in the last 10 minutes are, first, I want to give you an update on our contracting. Jane alluded to the fact that we have named Milliman as the apparent successful bidder to assist us with this project. As the group might recall from our first and second meetings, the legislator appropriated funding to OIC to assist with this work, including doing an actuarial analysis. And really what we've been trying to achieve is for that study and the report to have the available resources to cover the fully insured commercial market, which is what the legislation says, as well as Medicaid. And so we've been working with HCA to achieve that. So at this point, we are working on, apologies, the lights in the Seattle office here went off, but I'm just going to keep talking. So we're working right now with Milliman on that contract, but our aim is for the contract to encompass both Medicaid and the fully insured commercial market. So the analysis that would be done and the data that Milliman would be pulling from the all-payer claims database and other sources would encompass both Medicaid and commercial. So that's where we are right now with that. we had hoped that Milliman would be on board. We'd have a signed contract with them for today to participate. But since we're still finalizing that and they're not quite on board yet, we weren't able to include them. So that's where we are in terms of the contract. And then I think this is directly relevant to the eligibility and services and the payment model that Greg and Tori were talking about. But what I want to present to the group today is for our next steps. OIC is going to be working with Milliman to get them on board, get a contract finalized, and start getting them access to the data that they'll need to do the actuarial analysis. But we need to determine what they're actually going to model. And the authorizing legislation directs us to look at the eligibility criteria, the payment methodology, and the services that would be covered. And what we want to present to the work group today to get your feedback on here in the future is using the BRE collaborative report as a starting place, as a basis for the assumptions that Milliman will be making for the actuarial analysis. So as Tori pointed out, there might be some differences in those recommendations and how specific they are. And we may, want to adjust here and there, but our thinking is that we've had a lot of work that's taken place to study these issues and to align with some, national recommendations, and we want to draw on that on that work. So our next step for OIC is going to be starting to meet with Milliman to give them the information they need to make those assumptions for the actuarial analysis. So I think that's the direction we want to go, and the question for the work group, which we want to memorialize in something written that everybody can review in the coming weeks and months, is basically how the work group feels about using the BRE collaborative recommendations and the OHSU and HCA recommendations as a starting place to inform that. Jane, do you want to add anything or revise anything in terms of what I said for the group?
Nope. Good job.
So I know it's 4:54, and again, we're going to be working on this and having something for the work group to react to in writing in the future, but I'll open it up for now for the time that we have. Does anybody have comments, questions, and feedback on that approach in our next steps?
So Greg, actually a question for you, and maybe to loop back with Tori on, is how much does, right, what's laid out in the BRE collaborative report, in the report prepared by NASHB, how much does or does that not align with the model that you and Tori described today?
So, to the best of my recollection, the BRE collaborative approach is in good alignment with this. I think it's far less granular in some ways, but I don't think there's any philosophical disalignment. I think where things get interesting, the bundled payment, you kind of break it down into which disciplines are going to be involved, how many times per month are they going to see a given individual, how much cost is there for each of those, that stacking that quickly gets out of my bailiwick and into the actuarial world. Whether or not to include something akin to that advanced care planning payment for the assessment model, sort of the enhanced CPT code for a primary care provider or an oncologist who's doing a deeper dive on assessing what is their need and should I refer them to the specialized palliative care team who would then be covered by the bundled model. That sort of thing, again, that's a little newer and more innovative, and not something Tori is familiar with it being done elsewhere. It's not something I'm as familiar with. but I really feel like we're not moving in anywhere differently than where the BRE pointed us.
Okay, that's helpful.
Appreciate that, Greg. So it sounds like we'll have to further define and make some decisions based on the framework laid out. And we'd love to, partner with you with others in the work group towards that as we get Milliman on board. Okay, it's 4:57. I'm going to open it up one last time. Comments, questions, feedback from anyone in the work group.
Nico, this is Leslie. I'm not in the work group, but I'm just curious how much of this aligns with current essential health benefits under the Affordable Care Act. That's one of the things I'd like to see at some point too, like coordinated care as potentially being covered by the Affordable Care Act, essential health benefits.
Leslie, you and I have had these conversations. So if I understand your question, it's making sure that what we're doing is a modification of existing benefits under the essential elements as opposed to creating new benefits that are going to be a significant cost to the state, right?
Wonderful. Thank you for translating for me.
I
As
mean,
much as it can be.
But Leslie, this is Jane. I think we DeLeca already did some analysis on this a long time ago.
Okay.
And I don't think the changes that we made in the updated EHB benchmark plan that goes into effect January 1 of 2026 would necessarily change DeLeca's analysis. And DeLeca can share that with Nico.
Okay, great. Thank you.
Yeah, I can get back to you, Leslie, and I know we had chatted about that earlier. Okay, without hearing any further comments or questions, I'll call the meeting here as we're at time. Greg and Tori, I want to thank you again for your time and leading a really helpful discussion. So I'll communicate more detail out to everyone who is on this work group in the email list as we work with Milliman to get them on board and work towards the goal of translating the work from the BRE Collaborative and what we've discussed here into the assumptions that it can be modeled, making some of those decisions. So thanks again, everybody, for your time. I'm available. My email is on, and contact information is on all the emails. Feel free to contact me with any questions you might have. Always happy to hear your feedback. All right, thanks so much. Hope everybody has a good evening.
Thank you.